Welcome everyone. This is Dr. Lars Thestrup, your new medical director, and today I want to kick off a series which I'm going to call Quick Hits. And my goal of this is to bring you snippets of information that I think hopefully will help you out in the field. For example, today we're going to be going over left bundle branch blocks, and in the future we're also going to be addressing different types of calls, maybe scenarios, and then potentially the new protocols that will be coming out in the beginning of January. So with that being said, let's go ahead and get started with a review of left bundle branch blocks. So first of all, left bundle branch block. So what is the normal conduction of the heart? Well, as we know, the impulse travels down the SA node, then it goes to the AV node, then it goes down to the left and right bundles, and then the septum's activated from the left to the right, and then you get the small Q waves and lateral leads. This is all great information, but really what that means is that's what causes you to have a normal looking EKG. Now, when you have a left bundle branch block, you actually have a conduction delay. That means basically the impulses travels first via the right bundle branch block to the RV and then to the left side via the septum. So this is what causes that unique EKG finding of a left bundle branch block. So what is the diagnostic criteria? There are really only a couple that are so important. So first of all, QRS duration greater than 120 milliseconds. That is the first thing you're going to be looking for. So if you see in your anterior septal leads, V1 through V4, you see a wide QRS, that's the first thing you're going to think about, right? The other thing you're going to find is you'll get this big dominant S wave in V1. That's that big, deep, slurred S complex you can see there in that photo in V1, and that is pathognomonic for basically your left bundle branch block. The other thing I want you to look at, besides looking at V1, is leads 1 and V6. If you go to lead 1 and V6, what you're going to find is this big, wide, monophasic, meaning they're going to look the same, R wave in the lateral leads. So lead 1, that's a high lateral lead. Lead V6 is a lateral lead. And just like that picture shows, you're going to see this big broad-based R wave. Now, they don't always have that notch, just be aware of that. But they're going to be very similar in appearance. So again, if we look at our lateral leads, I want to point out here, there can be different appearances of what that R wave looks like. So lead 1 obviously is a little different with, V6 there. Lead 1 looks like it has a little notch in it, V6 doesn't. But usually when you have a left bundle branch block, they're going to look nearly the same in lead 1 and V6. So in lead V1, if you take a look there, you can see a broad RS complex, and what that means is you have that big deep S wave. You can see that red S labeling it, and then you can see that teeny little speck of an R wave sitting on top there. Now sometimes you may not even have that little R, you may just have a deep S, but that is classic for your left bundle branch block. And if you look, it's greater than 120 milliseconds, and then you got that big deep S wave. The other thing you're going to look down in V6, remember you're going to look at lead 1 and V6, and you're going to start seeing that R wave right there. Now, this brings us into the next conversation of what's called appropriate discordance. Now, this is where we often think left bundles are STEMIs. So, discordance means essentially you have that deep S wave, for example, in your anterior septal leads, but then you have what looks like that ST elevation that's occurring at the same time after that deep S wave. That's actually normal for a left bundle branch block. Now, at the same time, if you look at lead V6, you're going to see a deep ST depression after you see that R wave. Now that's actually also discordance, and that's appropriate for a left bundle branch block. And now you may or may not see that in lead V1 or lead 1. So keep in mind, discordance is normal in a left bundle branch block. When you have concordance, that's when you have an issue. Now, what concordance would mean is instead in that lead V1, V2, V3, V4, let's say you don't have that ST, what looks like that ST elevation, but instead you have ST depression, which is following that deep S wave. That's abnormal and suggests potentially a STEMI with a left bundle branch block. Now, if you look at V6, let's say you didn't have that ST depression after that R wave, but instead you had ST elevation after that R wave. That's abnormal. That's called concordance, and that could also suggest that you're having a STEMI with a left bundle branch block. I'll do a whole different lecture on STEMIs in the blocks, but I just want to make you aware of that concept of discordance, which is normal in your bundle branch blocks, and then concordance, which is not normal. So what causes a left bundle? All sorts of things. The big ones for you: hypertension, ischemic heart disease, dilated cardiomyopathy. You can have an anterior MI. Then you have all these other syndromes. Hyperkalemia, call that the great masquerader. That can cause just about anything. And then obviously some dig toxicity. But the differential for a left bundle branch block is pretty big. So real quick, I want to show you this slide. This slide is pretty classic to differentiate your right bundle and left bundle. And I know I'm jumping a little ahead with this, but if you look at V1 for a left bundle and then you look at your V1 for the right bundle, you can see they look obviously different. Your right bundle has those two bunny rabbit ears, which we call the RSR. Your left bundle has that deep S wave. And then you have your concordance also, or your discordance in V1 in the left bundle, and you have your discordance in V1 with your right bundle. That means you have the ST elevation, what it looks like the ST elevation, your V1 on the left bundle, and then you actually have what looks like the depression in the right bundle in lead 1. Now in V6, you have that R wave in a left bundle branch block with appropriately discordance of the ST segment. And in a right bundle branch block, what you look for there is a slurred S wave, which comes after that R wave. So we will go into that in the right bundle branch block lecture, but I just want to present those two concepts as it's a great differentiator between the two. So here's an example. So how do I approach an EKG like this? Is it fast or is it slow? It looks like it's at a pretty good rate. If you trace it out, you're at about 80 beats, 75, 80 beats per minute. When you go to V1, you're like, hey, that looks a little wider than 120 milliseconds. So does it meet other bundle branch criteria? And then you can see, yes, you have a deep S wave in V1, and then you have that discordance of that ST segment. If you look down at V6, you can see that upright R wave in 1 and V6. So both have that upright R wave, and then both have that ST depression, that discordance coming right after that R wave. So this patient actually meets the criteria. You have greater than 120 milliseconds, you have a deep S wave, and then you have that upright R wave in 1 and V6. If you look at this, again, you have a wider than 120 milliseconds. You have the deep S wave in lead 1, lead V2, lead V3, and then you have that discordance with that ST segment. If you look at lead 1 and lead V6, you have that upright R wave, and then in V6 you also have that discordance with what looks like that ST depression, which is normal for that left bundle branch block. Again, another example, if you look at lead V1, V2, V3, you've got that widened QRS, or that widened S segment. That S segment right there is greater than 120 milliseconds, and then you have that discordance with that ST segment. And then if you look at lead 1 and lead V6, you have that upright R wave with that discordant ST segment right after, which is classic for a left bundle as well. Now, not to confuse everybody, but you do have something called an incomplete bundle where it doesn't meet all the criteria. If you look at the deep S wave in lead V1 in this patient, it is a little less than 120 milliseconds, but you still have that very deep S wave in that discordance of that ST segment, and then you still have an upright R with that slightly depressed ST segment in lead 1 in lead V6. I hope this is helpful. I know bundle branch blocks can be very challenging and sometimes masquerade as MIs, but the best way to do this is practice is looking at them, and there's also some great books out there that you can go over as well. But this ends our first quick hit on left bundle branch blocks. Coming up next is going to be right bundles.